If you're approaching your due date with your first child, you are almost certainly aware of the big debate around labor induction.
Oh, absolutely. It's a huge topic.
And rates are rising everywhere. For first-time mothers, what clinicians call nulliparous women, that trend brings up one really big question. Does inducing labor mean I'm more likely to end up with a cesarean?
It's the #1 fear for so many.
So today, we're doing a deep dive to get beyond a simple yes or no. Our mission is to break down a huge Norwegian study of over 12,900 first-time mothers who were induced.
A massive cohort.
And we're going to zero in on the most crucial variable, how the reason for the induction actually dictates how the baby is delivered. Whether it's a spontaneous birth, one that needs instruments, or a C-section.
Because the why matters. A lot.
Exactly. This is about moving past generalized fear and toward, truly informed decisions. You need to know the risks for your specific situation. And to do that, the study needed a baseline.
A reference point.
Right. And they chose pre-labor rupture of membranes, or PROM, for that.
And that's a really smart choice for a baseline.
Why is that?
Well, because it's so common. It happens naturally across all different gestational ages at term. And the protocol is pretty standard. Once you have PROM, induction usually starts within about 24 hours, assuming no other complications.
So it's a clean comparison point.
A very clean reference. And let's talk about the data itself. This is a robust study. It's a nationwide 2-year cohort from Norway's Medical Birth Registry.
From 2020 to 2021.
Exactly. And focusing only on first-time mothers is key because we already know this group has a higher inherent risk of a C-section after induction compared to women who've had babies before.
So out of almost 13,000 women, what were the most common reasons they were being induced?
3 big ones really stood out. At the very top was post-term pregnancy. That accounted for about 21.1% of all inductions.
Okay, number 1.
Our reference group, PROM, was second at 18.4%. And then preeclampsia or hypertension was third at 10.9%. So that really sets the stage for what we're looking at.
Okay, let's unpack that. Let's jump straight to the biggest risk. For a first-time mother being induced, which reason gives you the most dramatic, the most disproportionate risk of a C-section?
That is, without a doubt, the suspicion of a large fetus, sometimes called fetal macrosomia.
And that group had the highest C-section rate overall in the entire study. It was, something like 45.7%.
It's a shocking number. But the real key is the comparison to our baseline, to PROM.
Right. How much higher was that risk?
It was 4 times higher. The study uses a metric called the Adjusted Relative Risk Ratio, or ARR. For a suspected large fetus, the ARR was 4.39.
Okay, let's pause on that. The Adjusted Relative Risk Ratio. For you listening, this is so important. It means that even after the research is controlled for everything else, the mother's age, her BMI, other medical issues, the suspicion of a large baby, all by itself, still made a C-section over 4 times more likely.
The risk stands on its own. It's a huge independent factor. And the study brings up this profound clinical problem that comes with that risk. Just how imprecise our estimates of fetal weight really are.
This part was amazing.
It's incredible. 2/3 of the babies induced because they were suspected to be large. 64.1% of them were actually born below the 95th percentile.
So they weren't statistically huge at all?
They weren't.
Wow. So you have a high-risk procedure being started based on an estimate that's wrong most of the time.
Yeah.
And that's what's leading to this massive jump in interventions.
It's the ultimate double-edged sword. You intervene because you're worried about a truly large baby, but the intervention itself is what carries so much risk. That uncertainty is what drives that high C-section rate.
So large fetus was the most traumatic. What were some of the other indications that had, say, a significantly higher risk than PROM?
Well, maternal request really stood out. It had an RR of 1.91, so that's nearly double the risk of a C-section compared to the PROM group.
Just by requesting it?
Just by requesting it. And then we saw there's elevated rates for post-term pregnancy, for oligo or polyhydramnios, preeclampsia, and diabetes as well. Your risk profile really changes depending on why you're walking in that door.
We've talked a lot about the C-section risk. What about instrumental deliveries? An operative vaginal birth, with vacuum or forceps. Did that risk follow the same pattern?
That's where things get a little different. The risk of an operative vaginal birth, an OVB, showed less variation overall. But, and this is a key butable, post-term pregnancy, diabetes, and oligopolyhydramnios all had a notable jump.
How much of a jump?
About 23 to 29% higher than PROM group. So they might avoid a C-section, but they are more likely to need some help at the end.
That brings us perfectly to the most common indication you mentioned, post-term pregnancy, which was over 20% of these inductions. This is an area with a lot of debate, so let's be really clear about how this study defined post-term.
Right. So the Norwegian guideline they use defines post-term as a pregnancy that has reached 42 weeks. Specifically, 42 plus 0 to 42 plus 2 weeks.
Okay, so that's the baseline.
But there's a really important modification. If the mother had certain risk factors like being 38 or older or having a pre-pregnancy BMI over 35, then screening and intervention started earlier, between 41 weeks and 41 weeks and 3 days.
That's a great example of clinical nuance. It's basically saying, if you already have higher background risks, we're not going to wait as long. We speed up the timeline.
Exactly. It's risk stratification in action.
But what about the timing? I mean, does the actual week of delivery change these risks? 2/3 of the women induced for being post-term actually gave birth at 42 weeks or even later.
Yeah, and that's where it gets really interesting.
How did the risks change when they looked at deliveries happening after 41 weeks?
That 41-week mark was a critical turning point. For the group induced for being post-term, after 41 weeks, they're a higher risk of a C-section. It basically vanished when compared to PROM.
It vanished.
It did. Their R dropped to 0.78, which means there was little to no statistical difference in their C-section risk compared to the PROM baseline once they were in that late-term window.
That is a crucial finding. It suggests that once you get that late in pregnancy, the challenges of just being late start to even out the risks for everyone. It's less about the specific post-term label.
And more about the simple fact of being 41 plus weeks pregnant. The risk goes up for everybody, which makes the specific risk from being post-term less distinct.
But not for the large fetus group.
Not at all. In stark contrast, their risk profile stayed dangerously high. That 4 to 6 times higher risk of C-section was consistent across all gestational weeks. That indication really is in a class of its own.
And did any other indications sort of normalize after that 41-week mark?
Yes. Preeclampsia and a category called other fetal conditions, they both showed a higher C-section risk before 41 weeks. But that extra risk also disappeared at normalized after that 41-week threshold.
So it really does seem like that late-term window levels the playing field for many of these common reasons for induction.
It really does.
Okay, so let's shift focus. Let's move from what the delivery mode was to why it happened. The study also looked at the reasons for intervention, like fetal distress or prolonged labor.
Right. This is where you uncover the underlying pathology. So let's start with fetal distress. This is a time-sensitive reason to intervene. The highest proportion of operative deliveries, so both C-sections and instrumental births that were done for fetal distress, happened in the intrauterine growth restriction, or IUGR group.
Wait, but that seems counterintuitive. Didn't that group have the lowest overall C-section rate in the whole study, something like 14.4%?
They did, but, and this is the key, if an intervention was needed in that group, it was almost always because the baby was in distress. 76.8% of their C-sections and 76.4% of their OVBs were triggered by it.
So if you're induced for IUGR, you've got a good shot at a vaginal birth, but if things start to go sideways, the team's threshold to intervene is incredibly low.
Precisely. They are prepared for a sprint, not a marathon, because that baby is already considered vulnerable.
Okay, that makes sense. Now, what about the flip side? Prolonged labor, a failure to progress.
This is where the post-term indication comes roaring back. Post-term pregnancy had the highest proportion of C-sections done because of prolonged labor, nearly half of them, 48.2%.
Which makes perfect physiological sense, right?
Yeah.
If you're inducing post-term pregnancy, you're often starting from scratch. The body isn't ready. So, of course, it's going to be a longer, more difficult process that's more likely to stall.
Exactly. And to tie it all together, the large fetus group, which we know had the highest C-section rates, also had the highest rate of operative vaginal births due to prolonged labor, a staggering 65.8%.
So the baby size creates a mechanical problem during the pushing phase.
It's just mechanical obstruction. They can't quite get out, and they need that instrumental help, even if they manage to avoid a full C-section.
So if we pull all this together, the reason for the induction is basically writing the clinical playbook for the delivery. If it's IUGR, you're watching for fetal instability. If it's post-term, you're settling in for a long haul. And if it's a large fetus, you're bracing for mechanical difficulty.
That is the core clinical takeaway from this data. The indication itself changes the management, the expectations, and the threshold for intervention from the moment you start. So to synthesize the main takeaways for you, the reason for IOL is, without a doubt, strongly linked to the risk of a C-section. Suspected large fetus carries that highest risk by a factor of 4.
A huge number.
The risk of an operative vaginal birth varies less, but it's definitely elevated for postterm and diabetes. And critically, while risks do go up for everyone after 41 weeks, the relative C-section risk for a postterm pregnancy essentially normalizes. It becomes statistically the same as our PROM baseline in that final week.
Absolutely. And that finding about postterm risk is so pivotal. The study authors suggest that for some of these high-risk but not immediately critical situations, like a suspected large fetus or even a maternal request, it might be time to discuss other options.
Options like what?
Like either waiting a bit longer for spontaneous labor, or, and this is key, having an upfront conversation about a planned primary cesarean as part of that shared decision-making process.
Moving the decision earlier.
Yes. And that leaves us with a final provocative thought for you to chew on. And it brings us right back to the beginning. Given that 2/3 of the women in this study who were induced for a suspected large fetus had babies of a normal size.
Which is just an incredible statistic.
It is. How does that known imprecision in our fetal weight estimates affect the entire cascade of interventions? If that initial diagnosis is wrong so often, what are the secondary effects of that uncertainty on a mother's confidence, on clinical decision-making, and on the overall intervention rate in modern obstetrics? Something to keep exploring.